I'm just going to get started. Good evening, everyone, and thank you for joining in for this professor's round. And I'm Dr. Venkat. I'm one of the anesthesiologists with a clinical focus and interest in neuroanesthesia at Toronto Western Hospital. I'm going to give a talk on known knowns and known unknowns in neuroscience. So I know most of you may not be doing neuroanesthesia, but this is not a neuroanesthesia talk. This is more of a basic neurophysiology, which is suitable for all anesthesiologists. So with this background, I'm going to start. So I have nothing to disclose. Most of the images I'm going to show are referenced for the articles from where it has been taken. And some of the images are borrowed from Google. So as you all know, as an anesthesiologist, the end organ of our anesthetic medication is the brain, and quite mysterious structure. And with so many years of research, both the laboratory as well as the clinical research, and we have been trying to understand various parts of the brain. And still we are struggling to fully understand the functions of various parts of the brain. And you probably, some of you might remember Donald Rumsfeld, and he made this very famous quotation while he was talking about when he was a US Secretary of State during a news briefing in 2002. And this was one of the very famous quote and attracted a lot of publicity and comment. And despite the several decades of laboratory and clinical research, Rumsfeld's assertion can be applied to the current state of knowledge about our understanding of the brain. Though there are relatively large concept of brain which are known to us now, and there is some of the concept which were unknown previously, especially with the advances in research methodology as well as imaging techniques, have facilitated to uncover a plethora of knowledge to arrive at a state of known unknowns. So I'm going to more focus on the known unknowns part of it on this part of the talk. And so with this background, my objectives are to review the important anatomical and physiological considerations relevant to neuroscience, and to discuss the concept relevant to anesthesia that are relatively unknown, which has come into light in recent years. So to start with some of the known knowns so that you don't get overwhelmed. So these are the basic med school stuff. We have been learning it all the way from maybe in the high school as well. So as you probably know, the brain is made up of two structures. Basically, these two structures make up of the whole of the cellular component of the brain. So we are very familiar with neurons, and but the glial cells is still kind of, we know some of the functions of some of the cells, but some of the cells we are not very familiar with. For example, we all know the Schwann cells and the oligodendrocytes are responsible for myelination. Astrocytes support, give nutrients as well as involved in processing information. And the ependymal cells are the lining of the CSF pathway. They forms a bigger part of the blood-brain barrier. The one mysterious structure here is the microglial cells. We never understood what the microglial cells did. So it was thought that microglial cells are responsible as kind of functions as a phagocytosis in the brain. But till recently, we never understood, we never focused on the microglial cells. So again, we are all very familiar with the beautiful circle of Willis, and which we all have, which is very unique, and wonderful collateral system, which prevents getting quite significant neurological deficit in the case of cerebral ischemia. We also very familiar with the CSF system, and so you know it forms in the choroid plexus and passes through the lateral ventricle, third ventricle, down to the fourth ventricle into the spinal cord. And we always thought that the CSF acts as a shock absorber, also as a mechanical buffer. It's a medium for a nutrition exchange and as well as a transport of hormones and chemicals. And finally, it's also as a part of transport of waste products from the brain. And this wonderful blood-brain barrier, which is very unique and which restricts the fluid, which restricts the passage of molecules and solutes across the from the brain to the brain cells. And so we know the functions of the blood-brain barrier and the conditions where the blood-brain barrier is going to be disrupted and the adverse events of disruption of the blood-brain barrier. And we also know that the brain is very unique. Being a small structure, it consumes a lot of oxygen and a lot of glucose as well, receives 15% of cardiac output, and neurons are very sensitive to hypoxia than the glial cells. So that's why the oxygenation is really important for the brain part. And we also know that the brain uses glucose as a primary source. Almost 90% of the energy comes from the glucose at rest, and 10% comes from lactate. But it has got a capacity to adapt to different fluids, different substrates for its energy. For example, during exercise, the lactate goes up to 40% and the glucose to 60%. And during fasting and then very stress and ketotic state, and various substances gives out the energy, acts as the energy substrates for the brain. So it is, even though it predominantly depends on the glucose at rest, but it has got a capacity to switch to different substrates for their energy. And we are all very familiar with this structure of the blood vessels. As you know, all the blood vessels have three layers: tunica externa, or adventitia it's otherwise called; tunica media, which is a smooth muscle layer with an external elastic lamina; and then the tunica intima, which is where the endothelium and subendothelium is present. And all the blood vessels get a blood supply from Vasa Vasorum, and that is pretty much is a standard for most of the blood vessels. And we are also very familiar with the fluid compartments, the extracellular, intracellular, and there is interstitial and plasma parts of extracellular compartment. And the fluid transfer across the capillary wall depends upon the balance between the oncotic pressure and the hydrostatic pressure. We're very familiar with that one. So this is the background. These are things we know very well. We studied for so many years and we are very familiar. Now coming to some of the unknown knowns part of it. So same thing, coming back to the cerebral circulation, the wonderful circle of Willis, and it is complete only in 50% of the individual. So of the people who joined into this session today, only 50, maybe at most 60% have a complete circle of Willis. Okay, there is a lot of anatomical and physiological variation in circle of Willis. And also at rest, there is no flow across the collaterals. So if you inject on the right side, there is no blood flowing into the other side at rest. We all seen in, if you've been to the interventional neuroradiology suite, if you're doing an angiogram, if they inject on one side, as you can normally see, the dye usually stays on one side of the brain. It doesn't cross over the next side. And another important concept is that the circle of Willis is a very is an important collateral circulation, but it plays a significant role only when you have a major vessel occlusion. So for example, if you have a middle cerebral artery occlusion or anterior cerebral artery occlusion, and it is a part of the bigger collateral circulation, there is a huge network of other collaterals which plays a significant role. So circle of Willis plays an important part, but there is a huge amount of other collaterals. For example, the other collaterals, they can come from either intracranially, they're usually called leptomeningeal or pial collaterals, and more importantly, the extracranial also can supply inside the brain. A classic example is the ophthalmic artery. So normally, the internal carotid artery gives branch to the ophthalmic artery to supply the eye. So in patients who may have a carotid stenosis, sometimes the flow in the ophthalmic artery reverses it, so that in the case there is a retrograde flow coming through the ophthalmic artery, which can supply distal to the stenosis of the carotid. And similarly, the middle meningeal artery, superficial temporal artery, and maxillary and occipital arteries, they all can penetrate through the skull and can end up supplying some parts of the brain, especially if the brain really needs the blood supply. So there is a huge variation in this collateral supply, and the adequacy of this collateral determines the risk of stroke as well as the prognosis of stroke. Okay, not only the risk as well as the prognosis, which is very important. And we all seen people with completely occluded carotid on one side, 90% occlusion on the other side, but they never had a stroke. That is because they have developed a good collateralization, and so they completely bypasses the carotid circulation so that they have a good collateral, so they never get any ischemic events. So when you're coming back to the vascular structure, the cerebral vessels are very unique. Okay, we talked about the tunica adventitia, interna, and media, and a very significant difference is that is in the tunica media. And the tunica media in the cerebral vessels does not have the external elastic lamina, so they basically just have a smooth muscle. And again, the most of the peripheral circulations, they have a smooth muscles in a transverse fibers or horizontal fibers, whereas the smooth muscles in the cerebral vessels is circumferentially arranged perpendicular to the floor. I will talk about it, why it is important in the next slide. And cerebral vessels, they do not have a vasa vasorum. So how do they get the oxygen supply? Because we know the vasa vasorum supplies the oxygen to the blood vessels, but cerebral vessels does not have a vasa vasorum. So the circumferentially arranged smooth muscle fibers is really important because among all the organs in the brain, all the organs in the body, the brain has got a very unique autoregulatory capacity as well as the maximal autoregulatory capacities. And in order to do that autoregulatory capacity for constriction, vasodilatation with every time when there is a systemic changes in the blood pressure, your head movements. So that's why the vessels are arranged circumferentially so that they can constrict and vasodilate it. And they can go in for a complete constriction, vasodilatation very quickly, which you cannot do it with the transversely arranged fibers in. Also, the problem with this constricted fibers, circumferentially arranged fibers, is that whenever the blood vessels bifurcate, the circumferentially arranged fibers, they cannot continue at the bifurcation. So usually at the bifurcation, they usually have a weak portion at the bifurcation, which is Menares resistance. Okay, so people are interested in learning more about the intracranial vessel. This is a really good article, came out in 2018. So the weakness in the junctions where the bifurcation happens, and that's why the aneurysm usually happens at the bifurcation. As you probably know that the structure, as I said, there is no internal elastic lamina, and the muscle is the strongest layer of the blood vessel. And so if there is a weakness in the muscle, and that's why they get into the aneurysms at the bifurcation. And as you also know that the adventitia is pretty weak, and as well as the intima, if the intima is weakened by hypertension, smoking, hypercholesterolemia, and so if they have an aneurysm, and these are the risk factors which precipitates a rupture of an aneurysm. So most of the people who have a ruptured subarachnoid hemorrhage secondary to the aneurysmal bleed, and usually have pre-existing risk factors of smoking, hypertension, hypercholesterolemia, which weakens the intima, and especially the deficient muscle fibers, it makes the media is exposed. So the adventitia is the only layer left. That's why the aneurysms are pretty small as well. There's like 2 millimeters, 3 millimeter aneurysms, and they happen in the bifurcation and they rupture pretty easily. Again, when you're talking about the cerebral blood vessels, and because when you're talking about the renal artery or a splenic artery, so whereas the cerebral arteries there are 3 different types of blood vessels. Each of these each of the cerebral blood vessels may be of 3 different types. And the vessels which sits on the surface of the brain, they are called as the leptomeningeal vessels or pile vessels, and they are the large, thick, and they supply the constant supply, and they have an autoregulatory capacity and as well as a response to the external innervation. And then there is the penetrating arteries, and these are the perforators. When the neurosurgery, when they retract the brain and they take some of this blood vessels, maybe due to the pressure effect on the retractor, and these are the vessels that may get injured, or if they're putting a clipping around the aneurysms, they may take one of those penetrating arteries which runs through, which supplies the parenchymal arteries, which supplies the gray matter and white matter. The parenchymal arteries, they won't respond to the extrinsic stimulation. For example, sympathetic and parasympathetic activity does not have any effect on these blood vessels. Those sympathetic and parasympathetic have a role only in pile vessels. And the parenchymal arteries that usually have an intrinsic innervation from a perivascular nerves in, okay? So that's one of the reasons when all these people in ICU on levo-fed vasopressins, they don't get a stroke because the parenchymal arteries in the brain, they don't supply a response to the sympathetic and parasympathetic activity. And when you're talking about the sympathetic and parasympathetic, and parasympathetic innervation usually causes the vasodilatation, whereas sympathetic innervation is only on the pile vessels. So at rest, sympathetic activity have little effect on cerebral vasculature, but they become really important when you have hemodynamic challenges, okay? When you have a maximal sympathetic tone, and you cannot increase the blood pressure further, but you can decrease it. And what it indicates is that is in patient with cerebral ischemia, the sympathetic tone is very high. So it is a very difficult to increase the cerebral blood flow without resetting the sympathetic tone. So for example, classical example is that patient have a vasospasm and likely their myogenic control may be overwhelmed by the pathophysiological factors. So if you want to increase the cerebral perfusion to the tissue, the therapeutic intervention which you normally use is the milrinone, which kind of reduces the sympathetic tone so that when you raise the blood pressure up and the cerebral perfusion improves in. So at rest, sympathetic does not have any effect on the brain. And especially when you have a high sympathetic tone, it is very difficult to further increase the cerebral blood pressure without resetting the sympathetic tone. So people are really interested in that. It's a really nice review article came out in 2013 in BJA on sympathetic regulation of cerebral blood flow in humans, and a really very good review on this topic. So as I mentioned before, the cerebral vessels lack Vasa Vasorum. So how do they get the nutrient supply? So Vasa Vasorum is absent in the distal intracranial vessel. This is not a new finding. 1998, they showed that is the Vasa Vasorum is absent. And also that is the presence of Vasa Vasorum is actually pathological. Okay, so if the patient develops a Vasa Vasorum, usually secondary to the vessel disease, atherosclerotic, hypertension, and any of those conditions, whenever there is a vessel disease, and that's why they develop the Vasa Vasorum in order to get the nutrient supply. So the incidence of Vasa Vasorum related to the severity of atherosclerosis. So if somebody has got a lot of Vasa Vasorum, that may be a marker for severity of atherosclerosis. And we all know that the cerebral blood vessels are bathed in CSF, okay? So the blood vessels sit in the base of the brain. They are all bathed by the CSF circulation. And also that is the cerebral spinal fluid that may nourish the cerebral blood vessels through the adventitia, through the pathways in the adventitia, which may be analogous to the systemic Vasa Vasorum. As you can see, this was published in 1982, okay? Almost nearly 40 years ago. And there are a lot of studies which show that the PO2 is the highest among all the body fluids. PO2 in the CSF is the highest among the body fluids. So when you look at this graph, it shows that compared to the venous blood, the CSF PO2, it sits around the average around 50 to 60 millimeters of mercury. You can look at any blood fluids, any body fluids, the PO2 is going to be very negligible, whereas CSF has got. So that indicates that the CSF does play a role, not just as a fluid mechanical buffer, it acts as an oxygen supply to the cerebral blood vessels. Okay, so we saw the fluid compartments in the systemic circulation. We know extracellular, intracellular, and extracellular can be divided into interstitial and the plasma. Whereas when you're looking at the brain or cerebral central nervous system, it is a bit complicated because there is an additional fluid system, which is the CSF. So the CNS has got a 4-compartmental model with the plasma and interstitial space and the brain cells and the CSF. And the important part is that the interstitial space is very small, whereas periphery has got a huge amount of interstitial space. So when you're talking about it, and it is in continuation with the CSF. My apologies, so this should read as ISF, not ICF. So it should be interstitial fluid. This is the ICF, this is the interstitial fluid. So interstitial space is very narrow in the brain, and it is in continuation with the CSF. And so there are 2 barriers. There is a blood CSF barrier, and there is a blood-brain barrier between the plasma and the brain cells as well. So because of small volume of interstitial space and continuation of the CSF, and because of these barriers, which is semi-permeable membrane, and the edema in the brain usually refers to the cellular edema, okay? Whereas in a peripherally, when you're talking about the edema, usually refers to the fluid accumulation in the interstitial compartment, okay? So that's why the treatment for the edema in the brain is completely different when you have a peripheral edema part. And so that is because the blood-brain barrier acts as a semi-permeable membrane, and they have a tight junctions in. So the usual Starling forces, the hydrostatic oncotic pressure does not have any role in the brain. So the plasma osmolality became the key. That's why you get mannitol, hypertonic saline, or the treatments for cerebral edema. Those agents does not do anything in the peripheral edema. So again, previously blood-brain barrier is thought to be a separate compartment, and then there is a neurovascular unit, and people who never heard about the unit of a neurovascular unit is a coupling between the neurons and the vascular unit is what is called as a neurovascular unit. That's the main hub of all the functions happening in the brain. Everything is regulated by the neurovascular unit. Previously, they thought the blood-brain barrier and a neurovascular unit as 2 different entities. So now most of the people saying that they all become a single entity. The blood-brain barrier is more of an extended neurovascular unit. So again, previously thought the old concept is the blood-brain barrier concept, and currently they think about the blood-brain barrier as a part of the neurovascular unit. And there is more work source that there is a huge amount of a huge degree of heterogeneity of a neurovascular unit. As I said, neurovascular unit is the functional hub of the brain. So because that's where all the things are initiated and as well as propagated. And that way there is a huge heterogeneity among the individual, as well as within the individual, and the different parts of the brain have quite a bit of a heterogeneity as well. So that is why the effect of medication, effect of treatment, and response to different things, all because of the heterogeneity between the individuals on the neurovascular unit. So coming back to the brain metabolism, because we thought the brain is metabolically very active organ and uses glucose predominant fuel. And the problem is that, you see, we always talk about the metabolism only in the neurons, okay? Because we know we always consider neurons as the functioning brain cells, and glial cells are not that important. But the interesting part is that, you see, the glial cells and neuron behave completely differently when it comes to their metabolism. And the glucose metabolism in neuron, and they produces the ATP. Okay, so when you have a glucose, I'm not going to talk about the basic biochemistry. So they go into the TCA cycle, and then they finally active phosphorylation produces an ATP. And the second part is that when you're talking about the glial cells, and the glial cell predominantly produce lactate, whereas the neurons predominantly produce energy in the form of ATP, whereas the glial cell predominantly produce lactate. And the glutamine, when you have an energy comes out in the neurons, the neurons converts the glutamate into glutamine, and the glutamine get transferred into the glial cells, and the glutamine stimulates the production of lactate, so that the more lactate is produced, and the lactate is being fed into the neurons, so that the more energy is needed. So whenever the neuron is activated, and it cannot cope up with the generation of the ATP, so it gets glutamine release, and which goes to the glial cells and releases the lactate, and which goes back in. So what? Why do you need to know this one? Okay, what is important for it? So this is what this phenomena is called as an astrocyte-neuron lactate hypothesis. The point I want to make here is that a lot of lactates are produced by the astrocytes. As the neuronal energy goes up, the astrocytes producing a lot of lactate, which gets fed into the neurons. And it is helped by the glutamine released by the neurons. So that's why when you have a neural activity increases, there is a huge amount of energy requirement, and the astrocytes take glutamate, and the glycolysis happens, and a lot of lactate is produced. So brain just produces a lot of lactate. And so that's what the point I want you to understand. So when you're talking about the lactate and the brain tumors, okay, there is a elevation of serum lactate during craniotomy for resection of tumors. So people who've done the neurosurgical procedures, they notice that sometimes the patients may have a lactate anywhere between 3 or 5 or even 7 millimoles per deciliter serum lactate during the surgery, and without any signs of hemodynamic changes or any signs of tissue ischemia. And people have proposed a lot of theories, including maybe a positioning, a long duration of surgery, and the positioning causing a tissue ischemia, and even a high BMI, which probably related causing ischemia to the tissue related to the prolonged surgery and positioning part. And good news is that the intraoperative elevation of serum lactate during craniotomy for brain tumor is not associated with any morbidity or mortality. And they usually comes down by itself on the postoperative period. And the reason being is that it is due to the phenomena called Warburg effect, okay? And normally when you have a differentiated tissue, okay, they produce oxidative phosphorylation. In the presence of oxygen, they produce the ATP, and there is very small amount of lactate is produced. Whereas when you have an anaerobic condition, that's where you get a glycolysis, where a lot of lactate is produced. So we always consider lactate as is indicator of tissue hypoxia. So that's where lactate is produced. Whereas unfortunately the proliferative tissues, and especially they like tumors, and they have a capacity to undergo aerobic glycolysis even in the presence of oxygen, and they can convert the metabolism to produce a huge amount of lactate. So the lot of lactate is in the tumor tissues because the amount of energy comes out by the oxidative phosphorylation is very small for the fast growing proliferative tissues and tumors. So they convert the metabolism to produce a lot of lactate, because the lactate amount can be increased quite significantly. So we looked at it, serum lactate in patients undergoing brain tumors. So we found that is the people having a high-grade tumors, especially the glial cell tumors, because as you know, glial cells are the one who produces a lot of lactate. And the people who are having high-grade glial cell tumors, WHO grades of 3 and 4 type of brain tumors, we always notice that you see the preoperative lactate is high, and there is an intraoperative lactate as well. Can you please mute, please? Okay. And there is also, we also showed in 2018 that there is a correlation with the preoperative serum lactate and the MR, magnetic resonance spectroscopy, and as well as the tissue specimen, and they all have a elevated serum lactate, and especially when the patient's having a high grade of tumor. And what we saw is that you see a lot of people with a baseline lactate above 2, they are predominantly high-grade tumors, the grade 3 and 4. And we have seen intraoperative elevation of lactate as high as 10, 11, 10 millimoles, and without any hemodynamic changes or evidence of any tissue hypoperfusion. And they are also seen in aggressive tumors like meningiomas, and as well as the skull-based tumors, and as well as the metastatic tumors, because it is a very unique property of highly aggressive or proliferative tissue can produce lactate in. Okay, and recently there's a paper which showed that is a pre-treatment serum lactate has a prognostic marker in patient undergoing a brain tumor surgery, because higher the lactate, high aggressive the tumor, so that does make sense. So when coming back to the metabolism, so you know the brain is so active, it is a metabolically active organ. So whenever there is an active metabolism, you're going to generate a lot of waste. Okay, so what happens to the waste in the brain? And so the brain is a metabolic powerhouse, and we always talked about the fuels and the metabolic pathway for the brain. We never talk about the waste clearance from the brain. We all know it is very active, and these are the fuels you need and how the metabolic pathway happens. So you need to give oxygen, you need to maintain the glucose, but we never talked about the waste clearance in. So the reason last 5, 6, 7 years is the focus has always been on brain waste clearance in. And usually we also been taught that the brain doesn't have a lymphatic system, and so what does really happen to the wastage clearance? And the CSF is one of the possible explanation that CSF is responsible for the waste clearance. But as you probably know, the amount of CSF is pretty constant. It's only 75 ml in the brain and 75 ml in the CSF. The total is like a 150 ml. And it takes like a 24 hours to get that 150 ml of circulation turnaround. It seems to be a long time in order to clear the waste from the brain, especially when it is so metabolically active. So that's where the concept comes in into a glymphatic system, okay? And that's where the glial cells plays in a role. And the glymphatic system is a recently discovered macroscopic waste clearance pathway. And it has got a very unique system of perivascular tunnels formed by astroglial cells. And they are very efficient in the elimination of soluble proteins and metabolites. Okay, they're very similar to lymphatic system. It's a separate channel in, and they're very efficient removing the soluble proteins and metabolism. So why should I, what is the purpose I need to know about the glymphatic system? So that's where we come in. So we always thought about the anesthesia is sleep, and so you'll tell the patient that you're going off to sleep. So the glymphatic flow specifically happens during the sleep, and especially during the slow wave sleep, okay? And that is why when you have a poor sleep or a lack of sleep, and the waste metabolites accumulates in the brain, which is responsible for the mental sluggishness. And one of the mechanism or hypothesis behind the dementia is that the lack of clearance of these proteins, especially when you're talking about the Alzheimer's disease, they talk about the tau proteins. Again, tau proteins is not something newly generated when people have Alzheimer's disease. Tau proteins have always been there, but they are imaged tau proteins in the brain in patients with Alzheimer's disease because they are not being eliminated from the brain, okay? And the glymphatic flow is responsible for elimination of waste products. And if there is inefficient removal of waste products, and which can lead to the dementia. And if people interested in glymphatic system, there is a really nice beginner's guide in neurochemistry research in 2015. Again, if you're not a basic scientist, and there is a really nice review article came out in last year in Anesthesia and Analgesia. They talk about the glymphatic system function in relation to anesthesia and sleep states. So we talked about is that the glymphatic flow predominantly happens in sleep. Okay, so because we always thought that the anesthetic agent is not really asleep, and it is the altered state of consciousness, so the lymphatic flow is definitely affected by the anesthetic agents. And interesting thing is that because the dexmedetomidine sedation is more resembling the natural sleep, and where you're going to get a slow wave sleeps. And so preliminary animal studies does show that the dexmedetomidine facilitates the glymphatic flow compared to isoflurane. The only problem in the advancement in this field is that the imaging of the glymphatic flow is a main limitation to know further about it. But with this 7 Tesla magnet, and there is advance in imaging techniques, and probably in a few years, we probably know much more about how the anesthetic agents affects the glymphatic system, and then the role of the glymphatic flow in postoperative cognitive decline, postoperative delirium, and other aspects of it. So then when I talked about the first slide, when you're talking about the brain cells, so we talked about the neuron as a predominantly, but the glial cells, we talked about we know the functions of most of the glial cells. Only thing is we never know is the microglial cells. Okay, for so many years, we didn't know what the microglial cells do. They used to do. Now, microglial cell is a holy grail of neurosurgical conditions. Okay, you name any conditions in the brain, anything you don't know anything about it, it's all because of the microglial cells. So this is, for example, these are the functions of microglial cells. Pretty much they do everything, okay? Some of the good stuff like vessel pattern promoting, angiogenesis, neural development, triggering the repair, immune surveillance part of it. They also do some really bad things like toxicity to the neurons and release of inflammatory and free radical molecules. So they does have a dual function. So they also do a lot of good repair and the regeneration part. They're also responsible for inflammation and toxicity as well. And so because of that, there is kind of 2 beneficial functions is predominantly promote growth and clearance of debris from the brain to promote new blood vessels and as well as the new cells. And there is an activated microglia does a really bad thing, okay? And they have a neurotoxic function, so they become a pro-inflammatory microglia. Okay, so whenever the microglia get activated, they are all becoming like autoimmune conditions, like a pro-inflammatory condition, causing a neurotoxicity. But we don't know what changes, what causes the activation of the microglia to one direction to the other direction. It's a good microglia versus the activated pro-inflammatory microglia. And so, as I already mentioned, they play a role in almost all neurological disorders, as well as the neurological effects of systemic diseases as well. And now when you're talking about the NUV, which is a neurovascular unit, where the blood-brain barrier is a part of the neurovascular unit, and the neurovascular unit is the main functional hub of all the activities in the brain. Now they also include a microglia as well. The microglia plays a significant function in the actions around the neurovascular unit. So why do you need to know from the anesthesia and the microglia? Okay, so that's what I thought so. So when I did a PubMed search and search for microglia and anesthesia, which I did in early part of 2019. And as you probably see, the number of citations in anesthesia and microglia is last 4 or 5 years is almost tripled. Okay, and there is a huge interest in anesthesia. Pretty much everything, the answers we didn't know anything about anesthesia part of it, which seems to be pointing towards the microglia. So for example, this is a really nice editorial came out in 2018 talking about the targeting microglia is a new avenue of anesthesia and neuroprotection. They're talking about the ketamine. They're talking about all other neuroprotective agents like dexmedetomidine, how they modify the inflammation in the brain. And Josh Bell, you probably know, one of the UFT candidate anesthesiologist from UFT. He has done a really good review on anesthetic neurotoxicity and the role of neuroglia, how that neurotoxicity and neuroprotection happens via microglial functions. Again, the opioid, there's a huge amount of work on microglia and pain, and especially why the opioid addiction happens in, and why some people are resistant to the opioid effect, and the side effects is predominant in some people. Most of them can be explained on the basis of microglial function. Again, there is still a lot of work still needs to be done. From the anesthesia wise, as you know, there is like a good part of the microglia helps in maturation of the neurons and the neurotrophic effect of the microglia. So when you have a tissue injury as a result of surgery, and in addition of the anesthetic, which can lead to the activation of the microglia, which causes the pro-inflammatory microglia, leading to the neuronal injury or a failure to repair of the neuron. The same thing which came out in Anesthesia Analgesia last year. They talk about the double-edged sword because of the microglial reactivity in anesthesia and the developing brain, and how the anesthetic agents causes a microglial activation, so causes a neurodevelopmental impairment. But again, it is still early stages. Again, same problem like a glymphatic system. Still, we can't image a microglial activation, so we are still on the early stages of understanding microglial functions. So when I mentioned about neuropathic pain, so especially when you're talking about that the agents like ketamine, agents like lidocaine, how they effective in neuropathic pain is probably because of modulation of the microglial activity. Okay, so how the pathophysiology of neuropathic pain, as well as the treatment of neuropathic pain by ketamine and lidocaine, is all based on the activation of the microglia. So coming to the summary, so as you probably know by now, the neuroscience is an evolving field, and a lot of work has been done in the last 5-10 years in the neuroscience, which are more relevant to anesthesia part of it. And so many of the unknown concept has now become known, and there are still a lot of unknowns there, and hopefully in the next 5-10 years, we'll probably have a better understanding, and we probably solve the mystery behind the brain. So the understanding the evolving concept is the key for the practice of precision medicine, because we are all gearing towards the precision medicine. So we need to understand the different aspect of it, the heterogeneity of the neurovascular unit, and the heterogeneity in the collateral circulation, why some people get a stroke, they get a good outcome. Some people get a stroke, they have a really good bad outcome. Same thing, the onset of the opioid toxicity, opioid tolerance, opioid addiction, neuropathic pain. So everything we can be, hopefully we can understand the reason behind them if you know more about the basic neurophysiology and neuroanatomy. Okay. Thank you very much. Thank you for joining today. And that's a QR code. Can you scan it and give me your feedback? So that'll be very helpful. And I'm happy to take a few questions. Any questions? Nobody? If there is no question, either you understood everything so well or you didn't understand anything at all.
Looks like there's one question here in the group chat. Should we be using dexmedetomidine in our patients at higher risk from postoperative cognitive delirium?
I think that's obvious, yes, because a lot of work has shown that is the dexmedetomidine because it promotes the natural sleep-like sedation. So that is one of the reason it can help. And again, when you're looking at the glymphatic flow, probably if you know more understanding about the glymphatic flow and the effect of dexmedetomidine and the clearance of the waste, the brain waste products, so that does make sense. So that we can probably say that the dexmedetomidine may be very useful in that scenario.
Venkat, Doreen here.
Hi, Doreen.
Hi, how are you? Thank you for doing this.
No problem.
Just wanted to know, in the situations of patients with increased intracranial pressure, what's known about the effects on the lymphatic flow system?
We don't know yet. So that's the whole. There's not much of work done fluid dynamics in the brain. Okay, the fluid compartments and what happens to the fluid compartments when you have. So it's basically when you're talking about raised intracranial pressure, so the CSF system is going to get squeezed in. So that does causes, as you probably said, the CSF does supply some part of the oxygen to the brain. Brain blood vessels, so that is what you're going to make the things worse. So it may causes a hypoperfusion, ischemia. It's not just because of the pressure effect on. And so again, coming back to the glymphatic flow, we have no idea because this is like completely new domain of understanding of the whole process. So we have no idea how the increasing the pressure in one compartment, how the glymphatic flow gets affected, because even didn't know how the glymphatic flow plays a role with the rest of the fluid compartment in the brain. They seems to be like a completely separate channel. Okay, any more questions?
Dr. Venkatesh, I have a question.
Yep.
This is Devashish Roy. Thank you for doing this for us. So recently I came across two conflicting things in one of the textbook, and they were saying about the CSF flow. Usually we know that the CSF is formed in the third lateral ventricle. They flow through third ventricle, fourth ventricle, through foramen and all these things, and ultimately get absorbed through the arachnoid granulation. Yeah. But they are saying that this is not the usual things. They get, it's complex and it is not absorbed.
It is like, so that's what our understanding is, that is they are getting absorbed through the arachnoid granulations. Because as I already said that, they usually thought the CSF pathway is a very unique, as a separate pathway. So they say, okay, it is produced and it gets circulated and it gets absorbed and new CSF is formed. But now there is more understanding is that there is all the channels in the brain are interconnected. So we don't know how the channels are interconnected in, because CSF compartment is in continuum with the interstitial space, and the brain does not really have a full fledged interstitial space. And the interstitial space is where the glymphatic flow happens in. So probably the CSF may also play a role in the flow of the glymphatics. And so again, so that's the original concept. Understanding is the arachnoid granulation absorption, but it may not be completely true. There may be something else happens in.
And my second question is that when we know that when in our other parts of the body, the metabolic products are like creatinine and other products. In the brain, is it different or it's the same?
No, it is like the metabolic waste depends on different organs anyway, though. So the muscle breakdown produces different thing, and the waste products of liver is different. Similarly, the brain waste products is a completely different one. So that's why the most of the waste products in the brain is we don't know what the waste products are. Okay, so we always thought a CSF clears them in. Whatever the composition of the CSF is different from the blood, and we don't know. We don't know a lot of things about the brain metabolism and the waste clearance.
Okay, thank
you. Again, that's why that's why the sleep and the glymphatic flow becomes very important. The mental cloudiness is very classic, and when you get older, the system slows down, and then more time it takes to get back to normal. Probably the amount of waste being accumulated is probably high. So again, the tau protein they talk about in Alzheimer's disease, tau protein is present from very early age. It is probably one of the metabolic waste products from the brain. And the only difference in Alzheimer's disease is that they are seen because they are not getting eliminated.
Thank you.
I think it's Doreen again. There's one more question on the chat that came up is, do you think dexmedetomidine would be useful in traumatic brain injury patients for protection?
Again, there is no evidence for the neuroprotective part of it. But again, dexmedetomidine, because it's the least effect on cerebral hemodynamics, as long as you avoid a hypotension, it's probably a better agent than conventional anesthetic agents. So again, there is nothing concrete that dexmedetomidine is definitely better than the other agents. Again, dexmedetomidine does not have any adverse effects as well, as long as the hemodynamics are maintained.
Just curious, sorry, it's Amaya from St. Mike's. Just the pragmatic utilization of dexmedetomidine. I know there's a huge amount of interest in the utilization of dexmed in patients undergoing any kind of cranial surgery, but it seems to fly a little bit in the face of what our surgical colleagues want from us in terms of rapid wake up in a patient who's totally reasonable in terms of post-operative assessment. Are we recommending dexmed in the form of a bolus at the beginning of induction, dexmed maintenance throughout the surgery, or is this only for the severely brain injured patient that's going to remain intubated and sedated in the ICU?
So great question. So the issue is that people always worry because of the pharmacokinetics of dexmedetomidine, the offset is really long. Okay, so again, when you're titrating the dose, and if you really wanted to assess the patient, so you probably need to stop the dexmedetomidine early, because there is single dose of dexmedetomidine. Probably the effect is more to do with the hemodynamic changes if you're going to give a bolus of dexmedetomidine, and the hemodynamic effect associated with the bolus compared to the infusion of dexmedetomidine is a completely different one, because with the dex infusion, you probably won't see that much of hemodynamic changes compared to the bolus dose. So again, if you're going to use it as a sedation during the craniotomy, again, you have to run it as an infusion part of it. And then post-operative sedation, not necessarily, again, if you're going to use it in traumatic brain injury, you want to assess the neurological status frequently, maybe dexmedetomidine may not be an ideal choice because of the pharmacokinetic profile. And they may be very good, and especially when you're in the phase of weaning from the ventilator.
Thanks.
Okay, thank you very much for everyone joining in.
Thank you, Venkat. Have a good evening, everyone.